All of March, April, June, we learn about operative dentistry, where we have decay, and then we put a little filling in, right? So we call those direct restorations because we make them directly in the mouth. So if you think about a crown, so what is a crown? So I know you guys are far from it, but this is a graduation cap, right? So the idea is that something fits circumferentially over what we'll call right now a little stump. Okay. So does anybody have any ideas why we'd rather do a crown versus maybe a MOD composite? Okay, maybe one at a time. Go ahead.
It's its strength. It's not like fraction of the tooth from like an MOD is like weakened.
Okay.
Forces,
So structural integrity of the tooth is weakened, right, Michael? There isn't enough tooth structure, right? Okay. So let's keep going down this road. So crown, basically like we described, instead of making it directly in the mouth, we use it to cover basically a stump. Okay. So we'll ask this question, right? When does a tooth need a crown? So we've kind of come up with 3 different reasons. And the first one we've all, some of the other classmates have touched upon, tooth structure. So the loss of tooth structure compromises its structural integrity, necessitating cuspal coverage for protection. So let's explore that a little bit more, right? So let's ask these questions. What causes the loss of tooth structure? So the first thing we'll explore is this idea of caries. So what is dental caries? Caries is an infectious microbiological disease of the teeth that results in localized dissolution and destruction of calcified tissues. So we have certain strands of bacteria, right? So Strep mutans, an example of one. Right? You guys probably knew a few more just about a month ago before your board's exam. So the idea is, yes, bacteria feed off some sort of source, sugars, to produce acid that then demineralizes the tooth structure. And what you're talking about, we have this idea of a critical pH level. As the pH in the mouth drops below, we're going to say about 5.5, is when that acid starts to demineralize the enamel, which is the protective outer layer of our tooth. Okay, and we asked this last time, the composition of enamel and dentin. So by weight, we have 95%, and for enamel, and just 5% organic. And by volume, it's about 86%. So you can see dentin is much less mineralized, meaning it's more susceptible to this demineralization process and thus dental decay. So the idea is that if we have, let's say, a previous restoration that has a large, has removed a lot of the tooth structure, you have decreased coverage or decreased cusp volume or structure that makes it susceptible to cusp fracture. So one of the reasons why, as we've lost tooth structure, the thing that we need to analyze is, well, what's the structural integrity of the tooth structure that's still remaining? Are we, maybe I should just stand in the front. Are we going to have this happen to one of our patients? Right? So cuspal protection becomes one of the first things we should think about in making this decision as to whether we need to redo an MOD filling, let's say, or if we need to protect the whole tooth by crowning it and circumferentially kind of covering the tooth. Okay. It is more invasive in the sense that you're grinding down more tooth structure, but you are protecting the integrity of the tooth by preventing some of the teeth, the cusp from fracturing out. So we sent out this article, right? Reduction in tooth stiffness as a result of endodontic and restorative procedure. Anybody kind of want to give us a synopsis of sort of the main point of what this author was trying to get at? So the idea is that as we drill away more tooth structure, then the stiffness of that tooth is compromised, right? So as we break down this article, right, the test that they kind of ran was they took an intact tooth and then they started to load it. Okay? So they did improve upon certain studies that they've done in the past. And I don't know if you guys read this carefully, but other studies that have been published, what were some of the disadvantages that they listed in their introduction as to why some of those tests weren't as meaningful? So one of the things they talked about is the previous studies they would load to failure, right? So they would take some machine, apply some force until the tooth broke. And generally those forces were beyond our kind of natural biting forces. So they did the test a little differently in the sense that they picked 110 newtons of force, more similar to our masticatory ability, and they loaded at that, and they put some strain gauges on the teeth to measure how much stiffness is present. Right? So they did that with a bunch of premolars, and really the part that I want to turn your attention to is, and I know you guys don't understand the endodontic part yet in terms of access and instrumentation, but the minute you go from unaltered tooth, which is 100%, to that MOD, you've lost 70% of the relative stiffness of that tooth. So a pretty precipitous drop in structural integrity. So that's if you did the root canal first. So in Table 2 lists, well, what if we reverse the order? So when you go from an untouched tooth to just a class 1, you've lost about 20%, right? Then you take away one of the marginal ridges, so let's say you do a DO, then that drops down to about 53%. And the minute you break through to both marginal ridges and you have an MOD prep, you're down to about, again, 30-ish%. So the idea is that as you remove more and more tooth structure, you compromise the cuspal integrity of that tooth. And you get to a point where the cavity or the filling is going to be so large that you want to say, hey, let's do the next step beyond a direct restoration. Let's do a full coverage restoration for the sake of protecting the tooth. So here it is just graphically, basically that previous chart just summarized with bars. So we've answered this question, right? What causes the loss of tooth structure? We've answered it the first way, due to caries. What we'll also talk about is attrition. So attrition is the act of wearing or grinding down by friction. So somebody that grinds their teeth, we call that or what's the act of grinding your teeth? It's bruxism, right? Bruxism leads to attrition a lot of the times. Not all the time. You can be a bruxer and not actually wear down your teeth. If we gave you, let's say, a night guard, and you grind down your plastic night guard instead of your teeth, well, you're a bruxer, but you've minimized or done away with attrition on the teeth. Instead, we've worn away a piece of plastic. Right? So grinding down by friction is what I want you to remember about attrition. How about abrasion? So abrasion is the wearing away of a substance or structure through some unusual or abnormal mechanical process. Right? So most commonly what we'll think about is toothbrush abrasion. So somebody that is really interested in keeping their teeth clean, maybe is overzealous and just maybe doesn't have the proper brushing technique. Right? So they take up this big hard bristle brush and they just hammer away back and forth, back and forth. Right? And what we expect to see, this is actually a radiation, or a patient who had radiation therapy, right? Their salivary glands were compromised, so the dentist told the patient, hey, you're at a high risk for developing dental decay. Right? And this patient was actually very good about keeping her oral hygiene, but so much so that she ended up brushing away a lot of our tooth structure, and then it's starting to stain. So this is an example of toothbrush abrasion, which is very, very common. Sometimes you will see people with other habits, like a toothpick, something like that, or by an unusual, how do we describe it? Unusual or abnormal mechanical process. So you'll see certain things like that. All right. Another form of tooth loss that we see is this theory of abfraction. I think Dr. Wong had mentioned some of this in your operative slide, but there's a lot of controversy about this. This is almost like religion. People will die for whether they believe it or not. But the idea is that if you've loaded the tooth too much, you flex the tooth, and where you're more susceptible to have some of those enamel rods and the dentin kind of flex is right at the cervical area. So you see this wedge-like kind of lesion on some of these teeth that have been, in theory, overloaded. So it's caused by biomechanical loading forces. So you just think flexure of the teeth, right? So we know that the tooth isn't entirely, we just went back and said, okay, enamel, about 95% mineral, but the inner surface, which is dentin, allows for flexure. We're only about 70% mineral structure, 30% organic, so we have some give, and it's designed so that we can absorb some of those forces and flex. So as the tooth flexes, sometimes it'll cause these defects. And again, this is probably the more controversial of the two, or of all the mechanisms. Some people really believe it, some people don't. If anything, we'll find that a lot of these causes of tooth structure are kind of grouped together. So it's multifactorial. When you look at a person's mouth, it may be due to one or more of these factors, right? So maybe it starts off as abfraction, and then they start abrading with their toothbrush because now the dentin's exposed and you have a softer area of tooth left. Okay. So what else? Erosion, right? So this is in dentistry, progressive loss of tooth substance by chemical processes that do not involve bacterial action, producing defects that are yada, yada, yada. The idea is that it's tooth loss substance by chemical processes, or loss of tooth substance by chemical process. So there's two ways we'll describe where that acid comes from, right? So one we would say is intrinsic. So what are some things that are associated with intrinsic acid? Bulimia, right? So this patient on your left, actually, I'll pull up the before and after. It's a bulimic patient. And you'll notice the erosion of the teeth. Where would you most anticipate finding erosion on a bulimic patient? What teeth and then what surfaces? Lingual of the maxillary anterior, right? So one of your lower teeth sometimes has that tongue to protect the way, so you kind of minimize the amount of acid exposure. But during one of their episodes, right, as they are kind of vomiting, you have acid encountering the lingual of the maxillary anteriors. So you can see on this patient, most of that erosion is concentrated in that region. You have some in the posterior. You see a little bit of that cupping. But you can see the upper maxillary right side, there's not as much as you anticipate, right? Okay, so what other systemic conditions may cause some of this intrinsic acid to be exposed to your mouth? Somebody said GERD, right? So you get that heartburn, right? Stomach acid has come up into the oral cavity. And now you've created an acidic environment that we talked about in the previous slides about that Stevens curve. 5.5 is critical pH for an animal. Okay, so what do you know about xerostomia? Right. So yes, xerostomia. If you have xerostomia, then you're just even in normal eating, right? Just your food, as you your body breaks down some food, your pH is lowered. So just even normal exposure to kind of daily habits would put you at higher risk for an erosive process. Generally not as significant as if you had added chemicals such as stomach acid, but yeah, you're at higher risk for developing some sort of erosion lesion because you have less protective factors. Yeah, I mean, patterns of erosion, yeah, so let's think about this, right? So we'll say bulimic patients generally, you know, it's going to be heavy towards the anterior. How about a GERD patient? Would that be kind of commonplace all over? Or so generally what we've seen is that sometimes patients, you know, they have these GERD episodes at night, okay, usually sleeping. So we do find sometimes that one particular side of the mouth is a little bit more exposed to the acid, you know, depending on which way they sleep, if they're having these gastric reflux episodes at night. But what Chris is saying is that, okay, let's just say you have xerostomia. I would almost anticipate that that is more generalized. So all the teeth are at kind of higher risk for that. Good question. So that's erosion, right? So that's intrinsic. How about extrinsic? What are some sources that we have outside of the mouth? Acidic foods. So classically, limes, lemons, soda. So Mountain Dew, right? So it's pretty commonplace in the Appalachians, right? Mountain Dew mouth is what they call it. And yeah, I mean, in certain cultures, obviously acidic foods are more popular, so you'll find a lot of times, you know, some erosive component there. And what you'll notice about erosion is you've taken your Explorer tip and you run along the tooth, it's just glass smooth, right? So the erosion really kind of almost polishes it up. What you'll also find is, you know, because sometimes you'll be looking at a tooth and you'll see some of the dentin exposed on the occlusal surface of your posterior teeth. And what you kind of want to distinguish is how much cupping there is in that dentin region. So you can imagine if somebody is just wearing away their teeth really aggressively, well, that tooth should be more or less flat if the only reason you're losing tooth is due to attrition. Right? There's times where teeth look flat, but then you also have a little cupped out region where your dentin is exposed. So in those cases, you want to think of other reasons why, you know, you have a little crater there. And the idea is that since dentin is less mineralized, right, it's easier to erode away. If you had some acid exposure, you're going to have a little cupping just in those isolated regions where you don't have that enamel being a protective factor. So intrinsic, extrinsic. Have to know a few of those examples of those. All right, so moving on, let's get back to this original question. When does a tooth need a crown? So we said, okay, to protect the structural integrity of the tooth. How about just to improve the aesthetics? Some patients will come to you and they'll say, I just don't like the way my tooth looks. I don't like the color or the contour. So this is one of the patients that came into our clinic. This is done actually by a third-year student. So what's cool is that in about a year from now, this could be you, right? So a lot to learn in the meantime, but this is what you guys have to look forward to. Patient didn't like color or contour of the teeth, had some decay in some of the teeth, and then we can do 6 crowns in the anterior and improve their smile. So the more you learn here, the better these results will be in your hands, the more prepared you guys will be for the clinic. Okay? So just a little bit of inspiration for you guys. All right, so we can improve aesthetics, right? Another reason a crown. How about change the contours? So we're going to introduce this idea of survey crowns, which you'll learn more about in November in your removable partial class. And the idea is survey crowns are fabricated to assist in the support, stability, and retention of a removable partial denture. So this is picture just to clue you guys in on. This is a removable partial denture. These are, let's see, which are the denture teeth? Denture teeth. So a patient has multiple missing spaces and wants to replace them, and we give them a removable appliance. Well, this removable partial denture has these little hooks, which in dentistry we'll call clasps. So this clasp fit onto the teeth in a certain way. So if a tooth doesn't have the proper contours for that hook to grab onto, we would then want to crown the tooth so that we can design the contour exactly how we want so that the clasp on the partial denture can hook on in the appropriate place. So you'll see this from time to time. Survey crown. Crown that fits onto a removable partial denture. Question?
Would you do that even if that tooth just doesn't have the right contour, but everything else is 100% healthy still?
Yeah, so it's a good question. There's moments where, excuse me, if the tooth has no caries, nothing wrong, the question is, can we do enough enamelplasty on the tooth to get it to the proper contours and not necessitate a full coverage crown? So a lot of the times we can. Maybe we just need to move the height of contour in one particular area, and we'll do some selective adjustment in that area for that appropriate clasping of the tooth. But there's times where it's so significantly out of position that we would say, you're better off doing a crown. And a lot of times, if you think about it, by the time a patient needs a removable partial denture, they've already lost several teeth, right? How do they get into that position? Well, we've probably had some either periodontal disease or some caries process. So most of the time, you'll find that neighboring teeth already have some sort of pre-existing restoration on it, either an existing crown or existing restoration. So you do tend to find many situations where, well, that tooth kind of needs a crown anyways, Okay. All right. Any questions about why we need to make a crown? All right, let's take a little break. We'll give you guys, about 10 minutes, and we'll get into actually the procedures of how to make a crown.